The government made me use that picture. I just have to tell you that. So first of all, I would just like to thank some of my colleagues at CMMI, the Center for Medicare and Medicaid Innovation, Susan Jackson and Aaron Smith, who are the program officers for the Strong Start program. The three of us work very closely together, and there's a lot of sort of give and take between the program and the evaluation side of Strong Start, and our division director, my division director, William Clark, and also the directors of the Rapid Cycle Evaluation Group, Will Shrink, who is going to be speaking, oh, hi, Will, in the next panel, and then, and Renee Metnich, who are just extraordinary, wonderful people, which I would have said even if you weren't there, Will. So to start off, talking just a little bit about what Strong Start is, for those of you who aren't familiar with the program, Strong Start has two components. The first one, Strong Start 1, is a nationwide public awareness effort working to improve the health of moms and babies by encouraging mothers and practitioners to let labor begin on its own. So you may have seen, we're partnered with the March of Dimes and with ACOG. You may have seen some things about the campaign. You know, the babies need at least 39 weeks to develop. We've really been trying to push the message of letting labor begin on its own. Rather than the 39 weeks, because it seemed to be confusing people as to the idea the 39 weeks would hit. Now I can have my induction. And so to really follow, and the new guidelines that have come out that have said, you know, that you don't want to do elective inductions in general before 41 weeks, especially with an unfavorable cervix, that we really want to push that idea that if your pregnancy is healthy, if there's no medical indication, let labor begin on its own. And the goal is to reduce the incidence then of early elective deliveries in particular, and also iatrogenic prematurity. So Strong Start 2 is investigating 4 different approaches to care. And one approach is being done through what we call the My Hope Strong Start. It's a home visiting program. It's a HRSA project that had a mandate from the Affordable Care Act, and it measures home visiting. And the My Hope Strong Start is particularly looking at home visiting programs of the Nurse Family Partnership, which was mentioned yesterday, and Healthy Families America. And so evaluation funds are coming from our organization for that initiative, but we are not in charge of the management of it. However, we do consult with them regularly. The other 3 approaches to enhance prenatal care are all being done through CMMI, and the evaluation is within the group that I was discussing before. And the goal of that is to reduce the incidence of preterm birth among high-risk Medicaid beneficiaries. And I'll tell you a little bit about our approaches. So the idea is particularly to target high-risk Medicaid beneficiaries. So merely being on Medicaid is not considered enough to be high risk. So even though poverty is a risk factor for preterm birth, and we take that very seriously, we are trying to target this intervention to the women at highest risk for preterm birth, both from geographic perspectives, demographic perspectives, and also from physical and other psychosocial risk factors. And that's actually based on IOM criteria, and I have a slide on that coming up. So our 3 enhanced approaches to care are care through birth centers, care through group prenatal care. It didn't have to be centering pregnancy care based for the grant application, but all of the sites who are awarded through Strong Start are implementing centering pregnancy as their standard for group care. And then what we call maternity care homes, and I really hate that word. It sounds like the 1950s places where you sent girls to be slut-shamed and take their babies away. It's a medical care home for pregnant women is what we're talking about there. So the awardees that we have, and I should have put the number here, we have 27 awardees. They estimate serving more than 80,000 women at 182 sites in 32 states. All right, so what counts as high risk? And again, these are the IOM criteria. They were put in our FOA, what does that stand for? Federally, whatever. Thank you, the funding opportunity announcement. We get so caught up in our acronyms, we don't even know what they stand for. So we have a whole long list of medical risk factors here, and then demographic risk factors and what the IOM categorized as social risk factors. And we asked our awardees to base the sort of risk factors that they were targeting on these criteria. So CMMI's focus, we talked a little bit yesterday about value-based medicine and what that meant. And so CMMI's focus is to produce better care, better health at a lower cost. And that's really our emphasis. And obviously, preventing preterm birth is going to lower costs through neonatal costs and all kinds of things. But we actually really care about costs beyond that early postpartum period. We're actually following mothers and babies for a full year. We care about maternal health as well as infant health. We are following those moms. And so looking at things like maternal morbidity becomes really important, as well as the neonatal outcomes, and then the prolonged infant outcomes. So things that we might see as repercussions through that first year. And that's where it becomes important to include things like breastfeeding and other issues that are really going to propel health for a longer period of time. So even though it's an initiative focused on prenatal care and preterm birth, birth setting, what happens at that birth setting, what happens at the birth become really crucial to the overall outcomes of those mothers and infants over the longer term. So Strong Start specific outcomes, preterm birth, we're measuring by gestational age and birth weight. We are aware that gestational age can be a very fuzzy measurement. That right now, ACOG's preferred measure is looking at an early ultrasound, a first trimester, ultrasound before 20 weeks, but an early ultrasound. But that often we wind up with LMP as a calculation, especially when women enter prenatal care later on. And then we're also looking at birth weight as a measure. So with low birth weight babies, again, who are not always premature, but works, the two in conjunction hopefully will work as a good enough proxy. As far as cost of care, we're looking at the woman's pregnancy, delivery, postpartum for 60 days, which is what Medicaid currently covers, but through a year of her Medicaid eligibility continues, and with the implementation of the Affordable Care Act, of course, we're expecting a lot of change in that, and so hopefully as the initiative goes on, we will actually be able to follow moms for the full year. And then infants who are automatically eligible for Medicaid, if they're born to a mother who was Medicaid eligible, to follow them from birth through a year. Some of the other issues that we're looking at in relevance to that is the length of stay for the delivery, NICU admission and length of stay in the NICU, and unplanned maternal ICU admissions. So there are a bunch of other outcomes of interest we have, looking at the frequency of a woman's ongoing prenatal care, the timing of prenatal care when she entered. For instance, centering pregnancy standards are that a woman enters care before 18 weeks. For the birth centers, standard of care is that a woman would enter care by 20 weeks to be, for inclusion purposes. And the maternity care homes will be working with sites individually to determine dates of entrance of care, but there is going to be some difference in timing of entrance of care, cutoffs among the three models. Looking at appropriate use of certain medical interventions like antenatal steroids for women at risk for preterm birth, the delivery, whether it's vaginal, cesarean, and we would also be concerned with operative vaginal deliveries, so use of forceps, vacuum extraction, et cetera. Because of our coordination with Strong Start 1, we're particularly concerned with elective delivery prior to 39 weeks, but we will be tracking inductions in general, elective and medically indicated. Looking at appropriately timed postpartum care for the mother. Medicaid does cover maternal care for 60 days postpartum. We want all those moms to come to their postpartum visit and get appropriate assessment for things like postpartum depression, future family planning, and breastfeeding success. And we're also very concerned with the patient experience of care, because we know, and this really coordinates a lot with birth setting, but also with the setting of prenatal care, that how mothers feel about their care and how they react to their care and their experience of it has a lot to do with the outcomes that they actually experience. So we have right now set up the idea that we will have three specific measures of care for moms, one at intake, one during the third trimester, and one at their postpartum visit. Especially to look at their experience of care between that third trimester and the postpartum visit, because the birth experience is so likely to influence their perception of their care. So for evaluation of our awardees, there are a lot of issues with this evaluation. It's extraordinarily complicated, and I think we've seen that from a lot of the other data that's been presented, or a lot of the other presentations, how complex it is to really be able to effectively evaluate birth settings, birth outcomes, and prenatal care initiatives, and so on and so forth, given all the differences in populations and approaches to care, geographic distribution, and all these kinds of issues. So the data that we have available and the program design vary by awardee. So with the American Association of Birth Centers and Centering Pregnancy, there are some standards that are going to be clear across sites, but with the maternity care home measures, they're proposing their own approach to maternity care, and there's probably going to be, well, I know for a fact because we have the awardees now, there's a large amount of variation in what's being targeted in those maternity care homes. Patient care coordination is a big one, and a large number of the groups are focused on that in particular, but there are a lot of other foci, and it also matters because Medicaid will cover different things in different states. Care enhancements that are offered are going to vary or have similarities both across and within care models. So we see peer counseling being offered both by birth centers and by some maternity care homes, various kinds of interventions that might be offered across some maternity care homes, but not all, might be common to centering pregnancy and the birth centers and some maternity care homes. So there's a lot of, crossover there. Very dramatic here. All right, so for our evaluation methods, we're taking a multi-pronged approach to try and capture as much as possible as we can among all of these differences. So we're looking at baseline comparisons, using a contemporaneous comparison group, use of site visits, interviews, and also using state Medicaid and vital records data such as the birth certificate, hoping to capture as much as we can by coming from all of those different angles. The issue with using a baseline to just say, okay, well, we had this group of people and we have a preterm birth rate and now we've put in this intervention and, and what are we going to see is because we're really looking at an approach to care and not just the enhancements that are added by Strong Start, the baseline becomes very complicated because the baseline would assume that you had standard obstetrical care, a woman visiting an obstetrician, having her 10-minute visit, so on and so forth. And then we suddenly had a new model of care. So we transferred from having that standard obstetrical model to a birth center or to a centering pregnancy model. And that's not really the case. So Strong Start, first of all, only pays for new enhanced care provisions that are not covered by state Medicaid. I cannot emphasize strongly enough that even though Medicaid is has a large federal component, it also has a large state component. And states make a lot of individual decisions about what Medicaid will cover. There's also different licensure issues. So for instance, CPMs are covered by Medicaid in some states and not others. So it becomes really complicated even to provide a standard set of enhanced care because some of it, is already being covered in some states, but not in others. Our birth centers, we have a couple of new birth centers that are going to be coming in later, as the years progress, but just a couple. So our birth centers are already in operation as birth centers. Many centering pregnancy sites and maternity care home sites are already operating as centering pregnancy sites or maternity care home sites. And then some sites are starting up all anew and they have no baseline at all because they're bringing in people for the first time. So that makes using a baseline a complicated proposition. Another approach to evaluation is to use what we call state-linked data. Some states link vital records with their Medicaid claims, and it allows us to look at the information from the birth certificate and then look at the Medicaid claims and make some comparisons of birth outcomes and what we see in that claims data. So I've actually been engaged for the last 6 months in a qualitative evaluation of the claims and data linkage. There'd been a lot of surveys out there, but what we found was we started to talk to people is that the data availability is so strikingly different among states, and why they're doing linkages is really different, and how they're doing them, what they're linking, all these kinds of things are so different. So we devised an open-ended questionnaire and have so far contacted about half of states to talk to their vital records and Medicaid programs about what that means. And so some states already are linking Medicaid records of mothers and their infants, but not all. Some states link some portion of these records, and they do it for a lot of different reasons. So some states only link a portion of them because they want to use them to set insurance rates, especially for states that have a combination of fee-for-service and managed care. They'll do it for the managed care people. To screen for Medicaid eligibility, so you'll have scenarios in which a state is capable of linking the Medicaid record with the vital record, but they'll only do it if someone brings in their birth certificate and says, I want to get on Medicaid, and they want to make sure that they were actually, the birth certificate is legitimate. Or they might do it to study a particular issue. So they may link a certain group or for a certain period of time because they want to look at something. It's not necessarily done on a consistent basis. And some states are doing it across the board all the time and have done it for years. I know Lori Cawthon is going to be reporting a little bit on this later, and Washington State is just sort of an exemplary model of the kinds of data linkage that can happen in a state, but don't necessarily happen at all in certain states. All right, so Dr. Barth covered a bunch of this birth certificate issue already. The medical portion of the birth certificate requests a wealth of information. And if it were filled out completely, we would have a lot of great knowledge, and the state medical linkage might actually be sufficient for evaluating the program. Gestational age and birth weight, the prime outcomes that Strong Start are looking at, are generally recorded on the birth certificate, recorded relatively accurately. But many other fields, such as these risk factors, which are huge for preterm birth, such as having a prior preterm birth, are not recorded consistently on the birth certificate. And it makes it really hard to rely then on vital records as an evaluation tool. Again, as pointed out by Dr. Barth and some others, the place of birth and the birth attendant aren't necessarily recorded consistently. So half of states are not routinely reporting the place where birth occurred. 11 states do not routinely report the name and title of the birth attendant. And then other midwife can mean so many different things, from a CPM who's licensed within a state to a CPM where there isn't state licensure, to somebody who's calling herself a midwife because she's been to a birth before, to whatever that might be. All right, so Medicaid coverage, as I said before, is largely determined by states. So some of the differences among states, the federal government does mandate that for pregnant women, Medicaid has to cover all pregnant women up to 133% of the poverty line, but states have the option of covering women who have higher incomes than that. And so some states go significantly higher than that. So the range of poverty, or the depth of poverty that women are experiencing who are on Medicaid, varies from state to state. Some states will cover prenatal care for immigrants who do not have legal status. Other states do not. They will cover the birth because technically that's for the baby. So the mother will get sort of an emergency Medicaid deal just for the birth itself, but no prenatal care would be covered. And so we have no idea through Medicaid claims whether or not she received prenatal care, because she may have sought it out on her own or through a nonprofit group or something. And then we also have these difference in Medicaid coverage of services. So some states cover centering pregnancy care, other states don't. And we have a big difference in coverage among providers. So Medicaid will cover providers who are licensed in a state, but because all states don't license all kinds of providers, that varies a lot from state to state. And this is an issue I wasn't aware of until I was chatting with some people yesterday, but because of some of the requirements within states for practice, even if the state will license the person, they might not actually be able to practice because of things like the requirements for liability insurance being so astronomical that it's not feasible to practice with those in place. State submission of claims data to CMS is lagged, and sometimes it's incomplete. Claims codes may not always be accurate. We, of course, are very concerned about issues of fraud, but if a vaginal birth and a cesarean birth are reimbursed the same in a particular state, it doesn't really matter what code goes down on the form. They're going to be reimbursed the same amount regardless, and we'd be paying out the same amount regardless. So in a state in which vaginal births and cesareans have the same reimbursement rate, there may not be much attention to which code is being put down, and so we can't necessarily use those claims to determine how many cesareans were occurring in that Medicaid population. And there may be global billing for pregnancy and birth. In fact, this is pretty common, that Medicaid pays a set fee for all the prenatal care and birth. So we have no idea how many prenatal care visits a woman had. Or it may be grouped categorically. So, 1 to 3, 3 to, 7, so on and so forth. So we know whether, she had a lot, a little, but we don't really know the exact number of visits, and can't really coordinate that with any of the outcomes or any of the complications she might have experienced. So for comparison groups, some awardees are only offering Strong Start service models to some eligible patients because they have a large number of eligibles. And we might be able to then look at the comparison of the people who were eligible but didn't receive the services within that organization, but that's a fairly limited number of awardees. Some communities may be large enough, especially our urban communities, that they have other sites not from the awardees, but just other hospitals or other practices that are serving high-risk Medicaid women, where we might be able to administer some instruments or get some medical records in which we could make comparisons. So that's another approach to trying to do the evaluation. We also need to consider care model bias, and this came up in some of our discussions that the panel had before the conference. In questioning, do women enroll in certain Strong Start sites because they're seeking a particular kind of care? So is there a particular kind of woman who seeks out a group care scenario? Is there a particular kind of woman who wants to go to a birth center? And if those women have substantial differences among them, does seeking a particular type of care compromise valid comparisons among care models? How do you control for those features that are sort of more personality based or attitudinally based? Can non-traditional care serve women with the same risk files as those in traditional care? So if you have a woman with preeclampsia, gestational diabetes, and a prior preterm birth, is it acceptable to care for her at a birth center as opposed to in a maternity care home? Are we really going to see those same kinds of risk profiles among the three interventions? And the other question that I would ask is, when women seek traditional care, is that also a bias? We often think of, woman going to a birth center, that's a bias. She's looking, one of these earthy, crunchy people who, wants to bury her placenta in the backyard and so on and so forth. But what about the woman who says, I want my epidural in the parking lot? I would never have my birth without a doctor. I would never give birth outside of a hospital. There's certainly plenty of people like that too. So people may be seeking particular kinds of care for multiple reasons, including what their insurance covers, what's available in their community. In a lot of rural areas, there may not be a lot of options. And even in urban areas, women may be constricted by transportation, childcare concerns, and other issues to go to a particular facility. So how much true choice women have and where they're pursuing their care is kind of up in the air. All right, providers, just to think about this in a maternity care home, women may see a number of service providers through care coordination: social workers, lactation consultant, nutritionist, OB, midwife, nurses. The primary prenatal care provider may or may not be the one who attends the delivery. In centering pregnancy, facilitators may have varying qualifications: RNs, CNMs, nurse practitioners, could be obstetricians. Often they're facilitated by a medical provider and a more lay-oriented person. The peer group is consistent, and the care providers are consistent for prenatal care, but the facilitators may or may not be the ones who attend the actual deliveries. And so often a woman going to her birth setting is meeting that practitioner for the first time. And then in a birth center, prenatal care providers are usually midwives, and the prenatal care providers are the ones who attend the deliveries, although it might be somebody who you've seen less, or it might not be the midwife you like the very best who winds up being the one attending your delivery. As far as birth settings go, in a maternity care home, there's no requirement for the setting, but it's almost always a hospital. It may be affiliated with a care provider setting or not. The woman may be receiving her care in the maternity care home and then go off to actually do a delivery at a facility that's not directly affiliated. Centering pregnancy, there's no requirement for the setting. It's usually a hospital. It may, again, be affiliated. The care may be provided at the hospital where the birth is going to happen. It may be at someplace totally different. The woman may be making her own arrangements for the birth. At a birth center, all awardees that we have are freestanding birth centers, and the woman is almost always then receiving her care at the same facility where she will be giving birth with practitioners with whom she's familiar. So finally, the participants. Many states and geographic regions, both urban and rural, are going to be served. We have a huge diversity, 32 states, areas with federally qualified health centers and extremely poor rural areas, other places, in the middle of Washington, D.C. The level and type of risk for preterm birth varies among and within states, as well as among and within the practices as far as what they're willing to take on as a risk. Demographic composition of the intervention participants may vary by site and region. So for overcoming the obstacles, we're looking at a combination of strategies, a triangulation strategy for approaching the evaluation, using state data judiciously, not just relying on it for the evaluation given its limitations, using some standard measurement tools, again, having an intake of third trimester and a postnatal measurement tool that are consistent across all the sites. and to do a lot of qualitative inquiry into the patient and caregiver experience and observation of what's going on at the prenatal sites and the birthing sites. Thank you very much.
Let's quickly move on to hear from our discussant, and that is Elliot Mann. He's been the director of the California Measures Maternal Quality Care Collaboration and has chaired the California Maternal Mortality Review Committee. So we're going to hear about data from his perspective.